Welcome to the first grand rounds of the new academic year. I have the pleasure of introducing Dr. Andrea Dunaif for her grand rounds on insulin, androgens, and cardiometabolic risk in women. Dr. Dunaif received her medical degree from Columbia University College of Physicians and Surgeons. She completed her internship and residency training at New York Presbyterian Hospital before completing fellowships at Massachusetts General Hospital in endocrinology, medicine, and gynecology. She held faculty appointments at Mount Sinai School of Medicine and several leadership positions within Harvard Medical School as a pioneer for women's health research. Most recently, at Northwestern University's Feinberg School of Medicine, she served as Vice Chair for Research, Chief of the Division of Endocrinology, Metabolism, and Molecular Medicine, and Director of the NIH-supported Specialized Center of Research on Sex Differences. She returns to Mount Sinai to continue her truly impressive work on PCOS, diabetes, and insulin resistance. Please join me in welcoming Dr. Dunaif.
Well, thank you very much. It's a great honor to speak here and to have such a nice turnout. And I hope to show you over about the next 45 minutes that you actually do see these women and that they are at very high cardiometabolic risk. And they're pretty easy if you ask the right questions to identify. And I think that androgens, and I mean mainly testosterone, are at least a risk factor for diabetes, if not cardiovascular disease in women, a previously unappreciated risk factor. So I have nothing to disclose. So let me start with the case, and this is an actual case we were consulted about a few years ago on the medical service, and it was a 39-year-old woman who'd come in for elevated blood pressure from her cardiologist's office, had difficult to manage hypertension for 20 years, already had coronary artery disease, which is remarkable. She was premenopausal, and severe dyslipidemia, otherwise no problems at the time. And here's how she looked, and she had a little bit of fullness around the face, and so I think the team thought about perhaps Cushing's syndrome. She was a little flushed, so they were thinking about perhaps pheochromocytoma, so those two things were why they called in endocrine. But as we took history, we also found out that she'd had increased facial hair and shaved. Reproductively, as I noted, she was premenopausal, and you know that premenopausal women usually are protected against heart disease. We don't start to see heart disease in women until about 10 years after menopause, which is in the early 50s. She also had had irregular menstrual periods, and in this case, it was prolonged and frequent periods. That's usually the most common form of regular menses. However, she'd been able to be fertile. She had obstructive sleep apnea, which turns out to be very common in these women with signs of androgen excess. Strong family history of hypertension, also early coronary disease, and of diabetes. So when I came to see her with the team, nobody had bothered to undress her to that point and sort of take a look at her whole body. And this is very common. I get referred a lot of these patients, and a lot, I mean, this is kind of a rare syndrome of partial lipodystrophy. But the reason people don't pick it up is they just don't look at the body habitus. And this decreasing of the fat rather precipitously around the buttock area and then in the extremities is really classic. And this phenotype is called familial partial lipodystrophy, and she had what we call the Dunnigan's type, which is with central fat. She's also quite hirsute, and this is just the very muscular looking legs because there's no subcutaneous fat. So these women with these partial lipodystrophy syndromes, which are genetic, are very insulin resistant. They often have elevated male hormone levels, and they're at risk for early coronary disease. They have high triglyceride levels, so they can get fatty liver and cirrhosis. And just sort of In passing, there is a medication now for this, metroleptin, where we replace leptin, which is missing because they don't have subcutaneous fat, and you can see marked improvements. But this case kind of brings up the question, are endogenous androgen levels a risk factor for cardiometabolic disease in women? And then are women who have high androgen levels at increased risk for diabetes and heart disease? And what do we mean by endogenous androgen levels? Those are the androgen levels that are made by the body rather than taken as a drug of abuse. So what we'll do first is go through the various hyperandrogenic disorders, kind of the main categories, talk about why these two findings of insulin resistance and androgen excess are associated, and that's really led to an understanding of a new biology of insulin, and then talk about long-term health risks. So these syndromes, though, as with almost everything in medicine, when you go back through Hippocrates, you can find descriptions of most of the things we think are recent, really came to the attention of the public in the 70s when rare disorders of insulin resistance were described by a Mount Sinai graduate, Jeff Flyer, and Jesse Roth, who trained with Burson and Yalow. And this was at the NIH, also Ron Kahn. And these were adolescent girls who had extreme insulin resistance. They required thousands of units of insulin a day to control their diabetes. They had a skin change, acanthosis nigricans, which is a sort of darkening, velvety hyperpigmentation. Whoops. Let me get this. Whoops. Sort of this darkening that you can see on her abdomen and around the neck is this lesion, acanthosis nigricans, and you can see that she's profoundly hirsute and masculinized, and we call this the type A syndrome, and these girls, adolescent girls usually, turn out to have mutations in their insulin receptor that either decrease the binding or interfere with the signaling of the receptor. The patient I showed you is another category of these extreme, and they have Mendelian inheritance patterns. The type A syndromes are usually recessive, the lipodystrophies are usually dominant, and the lipodystrophies are mutations in a variety of genes that regulate fat, subcutaneous fat. And your subcutaneous fat, even though it may not be attractive, is metabolically critical because it stores triglycerides. And if you don't have sub-Q fat, the triglycerides go into all sorts of bad places like your liver and your muscles and cause insulin resistance. So because of this rare syndrome, kind of awareness to hyperandrogenism and acanthosis nigricans was increased. And when I was a fellow at the Mass General, we started seeing or looking at our PCOS, which is a more common disorder, which I'll tell you about in a minute, but looking at them and noticing that they too had acanthosis nigricans. Whoops, I'm not going to be able to do this. If you can see this sort of raised, velvety darkening of the skin, and you won't find it if you don't look for it. So I commend you to look under the hair at the patient's neck. This is really very common and is a very diagnostic of insulin resistance. You can see she's hirsute, and these patients have a much milder form of insulin resistance and hyperandrogenism. They don't have any mutations in their insulin receptor, so they're a distinct phenotype of hyperandrogenism and insulin resistance that's quite common. And then another group of subjects, and you'll see why I'm including this, is women with upper body obesity. And it's been known, really it was popularized by Jean Vague in the 40s, that there were two body fat distributions. There was the female gynoid, big hips, and the male apple, increased belly. And he noted that in women who were apples, they had evidence of male hormone excess. They were hirsute. It's gone on to be confirmed that they have higher androgen levels, but they don't have the other features of polycystic ovary syndrome or these extreme syndromes. They have regular menstrual cycles and normal fertility. But what they do frequently have is the metabolic syndrome, which is a constellation of cardiometabolic risk factors, which is diagnosed by increased waist, increased blood pressure, high triglycerides, low HDL, and it's believed that these are all features of insulin resistance. And if you look in these women with metabolic syndrome and compare them to women without metabolic syndrome, they have higher testosterone levels across the board. And so the black bars are testosterone levels, and you can see for all the features of the syndrome, the abdominal obesity, triglycerides, low HDL, blood pressure, glucose, that the women with these features have higher testosterone levels than the women without these features. So this is a very common disorder, as you all know. So women with high androgens are out in your clinic populations all the time. So where are these androgens coming from? Well, in women, androgens are made by the ovary and also the adrenal gland. So the way the ovary makes testosterone, makes estradiol, is to first make testosterone under the control of the LH, which is luteinizing hormone. Guess I will stop trying to use the pad as a pointer. Luteinizing hormone, and then that LH, testosterone, under normal circumstances should be converted into estradiol, but under circumstances when there's a hyperandrogenic disorder, the conversion often is not complete because there's low follicle-stimulating hormone, FSH, which controls the capacity of the ovary to make that conversion. So if that's low, you've got more testosterone being produced by the ovaries. In some of these syndromes, like polycystic ovary syndrome, in fact, the ovaries, just under baseline circumstances, are making more testosterone. And then the testosterone appears in the circulation. It can cause the masculinizing symptoms. Mostly what we're talking about is hirsutism. Sometimes there can be hair loss. There's disruption of the normal feedback effects of sex hormones on the hypothalamus, and so there's continued drive to increased LH through increased GnRH, gonadotropin-releasing hormone production, and we get what's a vicious cycle. The adrenal glands and the ovary glands share the same steroidogenic enzyme, so we can show that many times women who have high ovarian testosterone production also have high adrenal testosterone production, and the exclusively adrenal androgen is dehydroepiandrosterone sulfate, DHEAS, which is a weak androgen and is really androgenic by its further conversion to testosterone. But women don't have to have high DHEAS levels to have an adrenal component to their hyperandrogenism. And then finally, testosterone is in the circulation bound to sex hormone binding globulin, SHBG, and it's only the testosterone that's not bound to that binding protein that gets into the tissue. So really the endogenous androgen that's biologically important is the non-SHBG bound or bioavailable testosterone. So how common are these disorders? Well, polycystic ovary syndrome is exceptionally common, and it's 7 to 15% of premenopausal women, and that's worldwide. In fact, the only ethnic difference is probably increased risk in Hispanic women. So we see the same prevalence rates in Asians, as we do in Americans and in Europeans. There's a little variation on the severity of the symptoms depending on the presence or absence of obesity. Women with just regular menstrual cycles and hirsutism are also exceptionally common in the population. And then there's a subset of women that I'll show you that we're finding in our research studies because we screen women for testosterone levels because we want control women that don't have high testosterone levels, so we're measuring them. And we found there's a very, very high prevalence of elevated testosterone just in women who have regular cycles and no symptoms. Then there's some less common disorders. Maria New here described a non-classical form of the adrenal enzyme defects, 21-hydroxylase, that presents just like women with PCOS in adulthood. And depending on your ethnicity, it can be 1 to 5%. It's more common in Ashkenazi Jews. We talked about the extreme insulin resistance syndromes. And then what we always worry about, which is ovarian androgen secreting tumors. They are very, very rare, and we hardly ever see those. So how do we diagnose the common disorder, polycystic ovary syndrome? Well, it's really a diagnosis of exclusion, and in 1990 there was an expert opinion conference, and the criteria were just hyperandrogenism. It could be hirsutism, or it could be elevated circulating levels, chronic anovulation, which is just irregular menstrual cycles, usually prolonged, greater than 35 to 40 days, and making sure they didn't have any other disorders. Europeans, because their practice patterns differ and they have their own ultrasound machines in their offices, they do their own ultrasounds, felt that the ovarian morphology was very important. This is a polycystic ovary, and they are not cysts. They are the normal structures that carry the eggs. Those are about 8 to 10 millimeters in size, and they're arrested in development because of the hormone imbalance. And if you give them the right hormonal stimulation, you will get ovulation and normal babies. So it's really a misnomer to call it a cyst. They don't grow, they don't rupture. And even in 1990, we knew that it was a very nonspecific finding, that normal women who had no high male hormones and no other symptoms could have this ovarian morphology, and women with a full-blown syndrome could lack the ovarian morphology. So in the US, we never felt that that was important. But in Europe, in Rotterdam conference, that was added as a diagnostic criterion. And so they added sort of a 2 out of 3 criteria, and this has been a bit problematic because it's led to multiple phenotypes of PCOS and made it kind of confusing. So we have 2 NIH phenotypes. Both are the hyperandrogenism and the irregular cycles, oligomenorrhea, with polycystic ovary morphology. Without the morphology, they really don't differ in any way between these two groups. And then we have these additional Rotterdam phenotypes, one with hyperandrogenism and ovarian morphology, and one with anovulation or irregular cycles and ovarian morphology. However, for us as internists and endocrinologists, when we sort of look at these different phenotypes, it turns out, by luck, that the easy to diagnose phenotype, just irregular menses and high androgen levels, are the group that are really at high risk for the metabolic problems that I'm going to show you. So this is sort of internist PCOS, and I will show you that it's easy to diagnose. And these women are at extraordinary metabolic risk. We're talking about women whose mean age is 20, but we see this in adolescents. And the green bars are national prevalence rates from NHANES. Blue bars are the simultaneously studied young control women matched for weight and ethnicity. And the red bars are the PCOS. And you can see that for IGT, impaired glucose tolerance, there's about a 30% prevalence rate in these women with PCOS compared to an 8% population prevalence, and already a 10% prevalence rate of type 2 diabetes in these women in their teenage and early 20s. And if we look at metabolic syndrome compared to population prevalence rates, when they get to BMIs over 30, and in the US about 80% of these women have BMIs over 30, they have about a 70% prevalence of metabolic syndrome. So they are severely, severely metabolically affected at a young age, so they're exposed to this adverse metabolic milieu for many years. Now here are the data just from our screening of control subjects for our study, control women, and with measurements of testosterone levels. And what we found is an increasing prevalence of high testosterone levels as we go up in BMI, the yellow bars. So about 15 to 16% of lean women have high testosterone levels, up to almost 40% of obese women, and we validated this in 2 different assays, looked at the distribution of the testosterone levels to show that this was a distinct population and not just the ends of the bell-shaped curve. So we feel confident about these findings. And then when you look at their risk, if they have high testosterone levels, they have about a 4-fold increased risk of having impaired glucose tolerance if they have a high testosterone level, and about a 5-fold increased risk of having metabolic syndrome. So these are women just out in the population that you would not pick up unless you measure testosterone, and it may be an argument for adding testosterone to a panel of identifying people at cardiometabolic risk, or women. So we thought of these disorders sort of as reproductive disorders or pediatric disorders where they're being seen for their menstrual periods, their hirsutism, infertility. They also come in for weight gain. They can have some psychiatric issues. But we really have to be aware of them because this is a huge cohort of women who also have metabolic disorders. So we're seeing them in our obesity clinics, in our cardiology and general internal medicine clinics. Their rates of prediabetes, which is what we now call impaired glucose tolerance, are exceptionally high. And again, they can also have anxiety and depression. So they're a target population for intervention to prevent metabolic disease. So what's going on here? And I think that's what really fascinated me when I was starting my career, is why were metabolic problems, diabetes, insulin resistance, associated with a reproductive disorder? And what were the mechanisms? So we had the old chicken and egg. Does the insulin cause the androgen excess or vice versa? So this summarizes years of work by many groups, but we now appreciate that insulin's a reproductive hormone. And it acts at the level of the ovary mainly, with LH to stimulate testosterone production. It can act on the pituitary to enhance LH release. It also increases the adrenal gland sensitivity to ACTH, which also enhances androgen production. And then insulin sensitivity in the brain is very important for ovulation. So if you make knockout models that are insulin resistant in the brain or the hypothalamus, they are anovulatory. And it makes teleologic sense. You do not want to reproduce if there is nutrient deficiency. And insulin resistance really is like nutrient deficiency because the nutrients aren't getting into the cells. So it turns out it's really a very ancient trait that we see in flies and worms, that if you decrease their food, they are going to stop reproducing. So a link between reproductive function and metabolism, it turns out to be very old and very important. Now also, androgens do cause some insulin resistance. So this is a study, and there are many of them, where flutamide, which is an androgen receptor antagonist, was given, and women were studied either on placebo or with flutamide, and these are women with PCOS. And this is that visceral adiposity. So if you take away the androgen, the visceral fat gets better, you get less visceral fat, and your insulin sensitivity improves. So androgens do cause some insulin resistance, and they certainly change body fat distribution. So the question I always get here is, what about men? So I'll show one male slide. And this is a very elegant study from Shally Bastine, and they did what they called a testosterone clamp. And they gave these men a long-acting analog of gonadotropin-releasing hormone, Lupron, which we use in prostate cancer to turn off the gonads hormonally, and that was used here. And then in a dose-response way, testosterone was added back. And you can see that even in men, when you give low doses of testosterone in the range we see in women with PCOS, these 25 and 50 doses, you do increase, and this is by DEXA, trunk adipose tissue, so it's a proxy for visceral adipose. You do increase it. And then as you give more testosterone, you start to see a decrease in fat and an increase in muscle. So it's really a biphasic effect. It's also true in women. We see, if we study female to male transgendered people, the same thing. As that we give very high male doses of testosterone, they will get reductions in body fat. So I think that accounts for the, quote, sex differences. Really, it's a dose response. So we now appreciate that insulin's a reproductive hormone, stimulates primarily androgen production. You have to have polycystic ovarian changes, and you have to have LH to have this effect. And that androgens cause some insulin resistance. But it doesn't explain the whole picture. So what else could be going on? Well, what about genetic susceptibility? And we had already been thinking about this for years because of the patients with the rare syndromes that were genetic. So, you know, one of my first grants from here, my first R01, I looked at the abstract, and we were trying to sequence the insulin receptor then by our very crude methods in the olden days. Well, it turns out what PCOS is not a Mendelian disorder. It doesn't have a dominant recessive pattern of inheritance. It's what we call a complex genetic disease. And that's a condition where there's susceptibility, but environmental influences. And you really need not only to have the genetic susceptibility, but the appropriate environment to manifest the disease. And probably the best example of that is type 2 diabetes, where you have to have diabetes genes, but if you don't become obese, you don't get the diabetes. So you need the environmental influence of obesity. And how do we quantitate that something's a complex genetic disease? Well, we see it cluster in families. And for PCOS, what we did was take a prospective group of families. We identified by the woman with PCOS, and then we looked at all the reproductive age sisters. And we found that about 40% of the sisters had some variant of PCOS. They either had the classic syndrome with irregular cycles and high androgens, or they had just high androgens. And so if you look at the prevalence in the sisters versus the population prevalence, 40% to 7%, you divide that, you get what we call the risk to siblings, which is almost 6, 5.7, which is very suggestive that there are genetic factors. And then a really kind of gold standard approach is to look within monozygotic twins with PCOS and see the sharing. And in a series of monozygotic twins, there's 70% sharing. So strong evidence that this is has a genetic susceptibility. And what that led us to do while we were trying to map genes was look at the family members, because if this is an autosomal, we had no reason to believe it was sex-linked, then maybe there are phenotypes in the families. We can only diagnose PCOS in reproductive age women because we have to have them being menstruating to have the irregular menses, and as you age, your testosterone levels tend to get lower. So here we're looking in the sisters on this side. The sisters who are blue bars have normal androgen levels. The sisters in the red bars have high androgen testosterone levels. So you can see if you have a high testosterone level, you have significantly increased risk for metabolic syndrome. And here are the mothers. We see the same thing. They have increased risk for metabolic syndrome. They're also insulin resistant. And the men are at risk too. So the male phenotypes are increased risk for being overweight. They're not really obese. Their BMIs tend to be about 27. Fathers, brothers, and increased risk for metabolic syndrome. So we see metabolic abnormalities. The younger males also do have higher androgen levels. And we see increased risk for type 2 diabetes. So another important factor when you're seeing these patients is to talk about the family members. We've detected parents with undiagnosed diabetes just by alerting the families that they also should get screened. And in terms of mapping genes, let me just summarize what's been years of work, but a number of pathways have been identified, including the receptors for the gonadotropins, LH receptor and FSH receptor. One of the gonadotropins, FSH beta, so that suggests that gonadotropin pathways can be involved. Ovarian genes have come up. Some of the diabetes genes, theta and the insulin receptor in these large-scale genetic analyses. And then, as with all these common diseases, we find a lot of genes that we still don't know what they do and we're working on. So PCOS is a complex genetic disease with risk to families, and a number of genes have been mapped. So let's wrap up with looking at what the long-term health risks are for women with high androgens. And do they have, if we look longer term, increased risk for diabetes or for cardiovascular events? So let's go back to metabolic syndrome, which, as I said, is a constellation of cardiovascular risk factors with dysglycemia, atherogenesis. They also have vascular dysfunction, endothelial dysfunction, evidence for inflammation, prothrombotic state. We don't know why these abnormalities cluster together. There are hypotheses that it's due to the visceral obesity, that it's due to insulin resistance, that there are genes. But if you're a woman, in particular, metabolic syndrome confers increased risk for you for cardiovascular disease directly and for cardiovascular disease through its increasing risk for type 2 diabetes. So metabolic syndrome increases risk for type 2 by about 5-fold. And once you have type 2 diabetes and you're premenopausal women, that abolishes the protective effect of being a woman on cardiovascular disease risk. So you have a risk, about a 5-fold increased risk of cardiovascular events just by having type 2 diabetes as a premenopausal woman. Also, you have a greater risk just from metabolic syndrome, even without diabetes, for cardiovascular events. So this adverse sex difference for metabolic syndrome and long-term risk. And this is just sort of to emphasize the point that diabetes in premenopausal women is a particularly adverse risk factor. So we're looking in the slide, if you don't have diabetes and you're comparing males to premenopausal females, males are about twice the risk as premenopausal women. But if you go and they develop diabetes, you increase the risk in the women by 5-fold, by only increase it by about 3-fold in men. And a premenopausal woman with type 2 diabetes is at greater cardiovascular risk than a man. And this situation, this is a 1999 study, this has only been getting worse in women, whereas cardiovascular risk has been improving in men. And if we look at whether testosterone itself is a predictor of diabetes risk, we can see that if you're a woman in the little pink squares, your bioavailable testosterone is associated with about threefold increased risk. And these are population-based studies of developing type 2 diabetes. So it looks on a population basis. If we just measured testosterone, it would be predicting diabetes risk. The situation, again, in population-based studies is controversial for cardiovascular events in postmenopausal women, and this is MESA, which is a multi-ethnic cohort, and they measured testosterone levels, and they found that testosterone levels were positively associated with increased carotid enamel thickness, one proxy for cardiovascular disease, but negatively associated with coronary artery calcification, which we feel is probably the best predictor of later cardiovascular events. However, and this is another cohort study where they went in and got additional information in testosterone levels, and they found, this is the Cardia study, and they found that testosterone levels and a history of irregular periods was associated with an increased risk for coronary artery calcification. Either one alone was not. So this is also very similar to what we see in PCOS, that the phenotype that's at risk is this combined phenotype of both the irregular menses and the high androgen levels. So out in the population, if you just identified women with these two findings, you'd be identifying a high-risk group. And in fact, we've done this, was sort of by accident, but we needed subjects for our research studies. So we put ads in the newspapers, we still do this, for women with 6 or fewer periods per year. That's all the ad says, doesn't say PCOS study or anything. And when we evaluate these women, 80% of them fill our very strict criteria for the diagnosis. They have high circulating testosterone levels. So that's an incredibly sensitive and specific question. Just are your menses, do you have menses less frequently than 6 times per year? And it's a striking enough event that women remember this. And it's not subtle. It's not like, oh, well, let me count. It's pretty dichotomous. So most women, have no problem answering this question. And in fact, it was so compelling, this is when I was at the Brigham, that my colleagues in the Nurses' Health Study collaborated, and in the nurses, they have 2 cohorts. They have an older cohort of nurses and a younger cohort. They're about 100,000 in each cohort, and they have data, even though the nurses are older, they have historical data from them on what their menstrual cycles were like when they were 18 to 20. So this is the younger nurses cohort where they had pretty good data, and this is in days, the length of their menstrual cycles. And we used as a reference range women who had about 26 to 39-day menstrual cycles when they were 18 to 22. And we looked in those at their development of type 2 diabetes. And they had a significantly increased risk of developing type 2 diabetes if their menstrual cycle length at that young age was greater than 40. And in this multivariate analysis, which adjusted for BMI and parity, smoking, all the confounders that oral contraceptive use that one would look at, there still was a 2-fold increased risk. And when we did the same thing for cardiovascular disease, we had to use the older nurses cohort, and this is a real problem in the field, that nobody has studied these women to an age where cardiovascular events in PCOS cohorts become common in women, which is the 7th and 8th decades. But these older nurses were in that age range. They only had descriptors of menstrual cycles when they were younger. We used the regular descriptor as the referent cohort. And the usually irregular and very irregular also had, in a multivariate analysis, an increase, and these are actual cardiovascular events. and the multivariate adjusted risk was about 1.5 or 50% increase in events. So I think these studies, they're not definitive, but they're suggestive. I also think what they do say is we ought to be asking about menses when we're discussing on and personalizing care for women, because certainly women with a history of irregular menses are at greater cardiometabolic risk. So what one question can you ask that will predict diabetes, metabolic syndrome, and cardiovascular disease? Nate? Right. And in fact, this has gone so far that the American Academy of Pediatrics has recommended that menses should be a vital sign. So if you could just ask that of your patients, it's an easy question, take you a second, you'll have much greater yield than a lot of the things we ask about. So, kind of to answer the questions that we posed in the beginning, so are endogenous androgen levels a cardiometabolic risk factor in sort of the general population of women? Well, they're certainly higher in women with metabolic syndrome, and metabolic syndrome, particularly in women, is an important risk factor for diabetes and heart disease. That if we look in a population of women who we found and measured testosterone levels, they were predictive of impaired glucose tolerance, prediabetes, and metabolic syndrome. And I guess it's still controversial whether in population-based studies just testosterone alone predicts cardiovascular disease risk, and that needs certainly further studies. And if we go to women who have one of these definitive hyperandrogenic syndromes, well, certainly women with PCOS, with what we call the NIH phenotype, the endocrinologist, internist phenotype, where we don't have to look at ovaries, which is just irregular menses, infrequent menses, and high androgen levels, that they are definitely at increased risk for type 2 diabetes. They are probably at increased risk for cardiovascular events, but we need the prospective long-term outcome studies. And that the irregular menses really is what identifies the subset of women with androgen excess who are at high risk. And that comes from that Cardia study, that you had to have both to have the coronary artery calcification, that just one wasn't as strong a risk factor. And importantly, with PCOS, we're identifying families at risk. So we should always suggest that family members have more intense screening. It's just like having a family member with type 2 diabetes. I think we should treat having a family member with PCOS. There's genetic variation. There are the rare Mendelian disorders. And then it's the common form is a common complex disease. So I think, and this is a slide from Ron Kahn. And so he has PCOS and hyperandrogenism as one of his features of metabolic syndrome. I didn't mention non-alcoholic fatty liver disease, but that is another thing we see frequently in metabolic syndrome. We have Derek Leroy and Emily Gallagher, who study the association with cancer. Very interesting association with Alzheimer's disease, and studies now going on using nasal insulin to improve cognitive function. And so, as I say, we can have the 5 o'clock shadow of the hyperandrogenic disorders added to the constellation of complications of metabolic syndrome. So kind of going back to the fact that this ovarian morphology is a misnomer and it's confusing, there was actually an NIH State of the Science conference that said that. They said, we believe the name is a distraction and an impediment to progress, and recommended a new name. And there is a process. It's very difficult because there are a lot of constituencies, but there is precedent for changing names of diseases, and this was done just 2 years ago where chronic fatigue syndrome was renamed, but they sort of did a compromise and made it a combined name, so it's even more complex. I can't even say the second word. So it's MECFS. And one of the major European leaders in this field and I decided we should also have a two-state solution. And the leading name now for the internist endocrinologist form of the disorder is metabolic reproductive syndrome, or Mrs. Metabolic ovarian reproductive syndrome, MORS, has been suggested. I tried syndrome XX. That didn't get very far. Another colleague of mine recommended the sexabolic syndrome. I didn't put it on there. So hopefully we'll have a better name, and it will make it more appealing to learn about it by the physicians who see these women after they've left the gynecologist. So I want to thank my collaborators. Rick LeGros is, in fact, another Sinai graduate and was my trainee and now is world famous, independently successful. Laura Torchin's pediatric endocrinologist, who's also on an outstanding path for independence, and the groups at Northwestern, and we've had collaborations through our center with the University of Wisconsin, and fortunately been fairly well funded over the years. So thank you very much, and I'm glad to answer questions.
Terrific, thank you. Two quick comments. There are 3 interns from my group in this audience listening to your presentation. That's pretty good because it was so many years ago. Secondly, when Jesse Roth decided to go from a hospital in Brooklyn where he was in training to work in the basement of a VA hospital, everybody thought he was crazy. The fact that that group, including Jesse Roth, ended up with a Nobel Prize just shows that he wasn't so crazy. Last point, once I have the microphone, if you took your beautiful lecture and talked about aging, how would it change some of your conclusions? Normal aging and all you've shown us.
Well, unfortunately, with normal aging, testosterone tends to go the other way. So we tend to see lowering of testosterone levels both in males and females, and so get into problems with loss of bone and loss of libido and frailty. I think aging's a bit of a different picture.
Do you have any clinical a clinical nugget for the internists here to dispense in terms of the lab workup for PCOS? Anything specific that you do? The lab
MRS.
MORS, yes.
So it's very simple, though it does depend on a lab that does testosterone assays by methodology that's called liquid chromatography tandem mass spec. So I don't know if LabCorp does that. I'm checking.
Don't mention
But Quest certainly does. So you can get a total and bioavailable testosterone. And in fact, if you order bioavailable testosterone from Quest, it's like getting a discount because they'll measure the sex hormone binding globulin and the total testosterone as part of doing that. The bioavailable is just a calculation. You don't have to measure free testosterone. We get a DHEAS. That's the new way to do 17 keto steroids. It's just a tumor marker. And then we rule out other disorders, though they're vanishingly rare, prolactin, TSH. No ovarian imaging is needed to make the metabolic, to identify the metabolic risk. And then most of these patients are obese, and so in order to detect their glucose intolerance, they have mainly postprandial dysglycemia. So they have impaired glucose tolerance, but not high fasting glucose. So unfortunately, hemoglobin A1C is not sensitive for detecting impaired glucose tolerance in PCOS because of this, and you have to do the fasting and glucose challenge, lipid profile, and maybe liver enzymes. There is a increase in non-alcoholic steatohepatitis, though it's unclear quite how much.
Andrea, diabetes moderately impairs cognition, impairs executive function, presumably because there's brain insulin resistance. Is there any evidence that PCOS also is associated with impairment in cognition?
So there was a fascinating poster at the ADA this year, the diabetes meetings, that used PCOS as a model for insulin resistance and cognition. And they showed that these women, after they'd been on metformin, had improved cognition. So they didn't have a control group to say if their baseline cognition was abnormal, but they showed it improved. And the very interesting, saying something about executive function, we did basal neuroimaging on a cohort. And the parts of the brain to do with executive function had some changes. So I hadn't realized that it was specific to executive functioning, so that would really be worth following up on.
The thing is, you don't want to screen unless you have a good treatment. In pediatrics, we tend mostly to use birth control pills because most of the young women are sexually active, and adults we tend to use metformin. Is there a right treatment that we should be using for these women?
I think you really have to customize the treatment so we don't have a cure, so it's very symptomatic. And they usually come in with three main issues. Their irregular menses, fertility, or their metabolic obesity. So for the women, the older women who would be coming to an internist, metformin is certainly worth a try because they'll lose a little bit of weight. It also improves their menstrual cyclicity. I agree with you, in adolescents, we're very worried about them becoming pregnant, and in fact, they can have enhanced fertility on metformin, and so we tend to avoid it in that population. And then there's specific ovulation-inducing agents. Fascinatingly now, aromatase inhibitors have the best outcomes for fertility in PCOS.
So Andrea, thanks for a wonderful summary. In the cartoon where you showed that insulin is a reproductive hormone, the premise is that there's insulin resistance in muscle and liver and fat, presumably, and yet insulin's still able to operate in ovary and perhaps adrenal and hypothalamus, etc. Is there direct experimental evidence for that? That would be tough for humans, of course.
So you can show, and we've shown in human tissue, that the insulin resistance, even in a target tissue, skeletal muscle, is selective. So only the metabolic signaling is impaired, so the activation of PI3 kinase, whereas the activation of the mitogenic pathways, ERK, MEK, is in fact constitutively activated, and the insulin receptor in PCOS, the mechanism of insulin resistance is it's got decreased tyrosine, insulin-stimulated tyrosine autophosphorylation, and increased constitutive serine phosphorylation. And serine phosphorylation is the off mechanism for these tyrosine kinase growth factors. And one of the kinases that serine phosphorylates, at least in skeletal muscle, is in the ERK-MEK pathway. So you can show selectivity within tissues. Then there are different target tissue sensitivity, and there's some beautiful series of knockout experiments from Andrew Wolf at Hopkins in different tissues, knocking out the insulin receptor and looking at the reproductive phenotypes.
Thank you very much. Thank you.